My name is Muthiah Vaduganathan. I'm a cardiologist and clinical trialist at Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. So when we conduct clinical trials, we often will power these clinical trials for specific endpoints. Often they're composites of important events that occur in a patient's life, like death from cardiovascular causes and hospitalizations for heart failure, as was the case in DELIVER and EMPEROR Preserved. However, neither of these trials were individually powered for the components of those endpoints, and neither were powered for important subgroups that we commonly see in clinical practice. So we pre-specified and pooled the two largest trials now of heart failure with mildly reduced preserved ejection fraction to evaluate those 12,251 participants between the two trials. So we took individual participant level data from the DELIVER trial and harmonized endpoints and subgroup definitions with trial level data that have been published and in the public domain from the EMPEROR Preserved trial. We felt that this harmonization process allowed for more rigorous meta-analytic approaches. We then evaluated the overall endpoint of cardiovascular death and heart failure hospitalization. We evaluated a number of other important clinical endpoints. And finally, we evaluated about 13 to 14 important subgroups that were well represented in both clinical trials. So we found in the overall meta-analysis of the two trials encompassing 12,251 participants that the SGLT2 inhibitors, dapagliflozin and empagliflozin, reduced that primary endpoint by 20%. And importantly, we saw concordant reductions and contributions by both of the components. We saw a 12% statistically borderline reduction in cardiovascular death and a very robust, statistically robust reduction in heart failure hospitalization. We furthermore saw important improvements in clinically meaningful changes in health-related quality of life as assessed by the Kansas City Cardiomyopathy Questionnaire, and we saw improvement in symptom burden with these therapies. We saw remarkable consistency across every pre-specified subgroup analyzed, including ejection fraction. And we found that these therapies actually improve clinical events even among those with an LVEF above 60%, a population where we had previous uncertainty about the extension of clinical benefits of SGLT2 inhibition. So we really took a deep dive in evaluating and summarizing the best available evidence of SGLT2 inhibition in an LVEF above 40% in this meta-analysis. We additionally took a step back and evaluated the totality of evidence encompassing 5 trials of over 20,000 participants. And in that more comprehensive meta-analysis, we found that the SGLT2 inhibitors reduced cardiovascular events, this is the primary endpoint, by 23%, heart failure hospitalization alone by 28%, cardiovascular death by 13%, and all-cause mortality by 8%. So really, these findings were highly statistically significant and importantly had no variation based on the populations that were studied in the individuals' trials, whether reduced EF, preserved EF, or worsening heart failure. And so for me, the message is one of simplicity. It is that SGLT2 inhibition should be an important therapeutic strategy for all patients with heart failure, barring contraindications, irrespective of ejection fraction, patient phenotype, or care setting, whether they're hospitalized or in ambulatory care. Yes, we took a deep sigh of relief after the completion of DELIVER, but of course there's much work to be done in implementing SGLT2 inhibitors at a broad scale amongst patients with heart failure, and especially at higher ejection fractions. This is a disease state that is only growing in awareness, and we have to make important steps and strides in early diagnosis and now integration of an effective therapy that has been added to now guideline-directed medical therapy for HFpEF.